For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 18 of Surfing the NASH Tsunami. Our look at the interplay of endocrinology and hepatology in treatment and knowledge development starts now.
This week on Surfing the NASH Tsunami.
It's really helpful to get this interaction and this symposium when we bring the knowledge of the hepatologist and the knowledge from the diabetologist and how we can manage this patient that actually we both see on different sides of the disease.
Or how can I communicate with my colleagues out there in endocrinology, and what can I tell them on how to use those NITs which we've developed as a hepatology community?
We've got clear parameters. We've got clear settings that we can discuss, and we know our field as intermediaries for that, and I think that's the key.
If in fact we started incorporated liver on that list, starting with prediabetes, I think we would start to see enough data and enough experience quickly enough that everybody would get a lot more serious about this.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guest, endocrinology researcher and key opinion leader Dr. Cyrielle Caussy, as they discuss the clinical and educational interplay of endocrinology and hepatology on Surfing the NASH Tsunami.
So this is the first week of our fourth year. Thanks everybody who sent in notes and comments after the birthday celebration. We didn't get anybody to play the birthday games, one person I guess, but lots of nice notes and comments, and I think I've written back to everybody, and if I've not, I'll get a note out to you within the next day or so, and thank you for that. I'm excited about tonight's episode. I guess, Cyrielle, I first met you...
We first met in Barcelona.
Yeah, in Barcelona last year, and she gave a fantastic presentation at Paris NASH that I was unable to see in person, and we've been trying to get her on the podcast. Originally, this was going to be the week that we talked about NICE and FibroScan, but that ruling hasn't come down yet. So Cyrielle was good enough to join us this week, and we'll get to that ruling when there's a ruling to get to. And this should be a fantastic episode. Cyrielle, welcome aboard.
Thank you, Roger. Happy to join the podcast.
Do all of us a favor, just take a minute or two and tell our listeners a little bit about your history and what you've done in your career to get to where you are now and where you are now. And then after that, I'm going to ask you to tell us, well, do that first, and then I'll have one more question for you.
Okay, just a little bit of background. I'm an endocrinologist, diabetologist, and also nutritionist. I'm working in Lyon University in France. I first started my medical school 15 years ago, I guess, and I was very also interested in research. So I took a break to do my PhD thesis and then started to get more interested in fatty liver disease. My main focus at the beginning was dyslipidemia and hypertriglyceridemia. And I was really interesting to see that there were no treatment for patients with NAFLD, and I wanted to get to know more and more about the disease, and I decided that the best way to be trained in this disease was to join a hepatologist, and this is what I did for my postdoc mobility. I joined the NAFLD Research Center in the University of California, San Diego, and I was very lucky to work with Roy Klumba, where I learned a lot during 2 years about the disease, and we did some research about imaging biomarkers, how we can identify familial risk of NAFLD, and it was 2 fantastic years. And when I went back to France, I started to build a program focusing on the detection of advanced fibrosis and NAFLD in my patient with obesity and type 2 diabetes. So basically, this is how short story long, but this is how I get to be an expert in metabolic disease and NAFLD especially.
And she is, Roger. I'm happy to have her on here. Hi, Cyrielle. It's a real pleasure. Again, I think I got to know her through her work, UCSD. The twins study was one of the things you've done, I believe, and really high-end scientific research and imaging. And I think we had an unsuccessful grant application soon after you came to the EU, but I've since then followed your work, and it's been really a pleasure to cooperate, and very happy to have you on the podcast tonight.
Yeah, that's right. We try to submit. We should try to build more collaboration as well. But definitely, yes.
Cyrielle, you're one of the few people I've heard described as a hepatoendocrinologist, which I think is germane given some of the publication you've done and what you work on these days, and that's great. So can you do us one more favor? We ask everyone who comes on for the first time to tell our audience one thing about your background that they wouldn't know or necessarily guess if you didn't tell them. So you have something you can share with us?
I can share a few things. I didn't do a lot of amazing stuff, but probably people doesn't know that I used to be a basketball player during all my childhood, and even when I started medical school, I was not in the very high league, but still we were champion in the regional league in my category. So I think, well, this is one of the little aspects of my story that probably people doesn't know.
So, Jörn, you think we should invite Cyrielle to go one-on-one with Mazen sometime? You know, Mazen Nuruddin.
Oh, yeah, that came to my mind immediately. That was his story.
He was a professional basketball player in Syria.
He was, okay.
But a vision comes to mind of Cyrielle holding the ball up and Mazen can't reach.
Dr. Nuruddin, Campbell's played them all.
Having seen them together and standing next to each other, then just that would be an entertaining game.
Actually, that would be really funny. Yeah.
All right, we'll do this one for charity at some event. That's excellent. So with that, why don't we just icebreaker one good thing, personal or professional or both, that's happened in the last week in your life. Brave one, go first.
Cyrielle was talking, so let me just get started here. We had the German's internal medicine meeting going on over the weekend. It's actually finishing tomorrow, and I was involved in one or two occasions. It was great to exchange during the meeting with colleagues and give some lectures on NAFLD and cirrhosis. So that was a personal highlight, being able to reach out and engage with peers.
And you've been in Germany all week?
I was, right? It sounds like a record.
For this year, it sounds like the first one of these that I can remember that you've been there for 7 days in a row. That's fantastic.
No, I've been, and I have clinic duties, and actually the semester is starting, so we have the students returning to the university and teaching starts, so it's a lot of responsibilities these days.
I suppose I'll jump in next. We've now started to see people getting through the app and booking fibre scans for just lifestyle and choice about knowing their liver health so that they can look at their health, wellness and well-being for early detection of any particular problems. So that's good. And the app's gone live in Australia as well. So we're getting there slowly but surely. We're trying to spread that world of life, of wellness and liver health rather than waiting for liver disease.
Okay. Cyrielle, go ahead.
The past few weeks, well, it's been also very busy trying to consolidate in Lyon the pathway. We are working with the hepatologists to build an institute, which is called the Lyon Hepatology Institute. So hopefully we have applied for a big national grant in France. We are expecting the results, so I hope it will be funded for a very large and broad multidisciplinary institute. That would be very nice. We were hoping to get the result this week, but the government has delayed the announcement, so we'll see. But we're very busy working on, building this institute in a multidisciplinary approach.
That's great. My first piece of good news is that Louise didn't talk about football, which was a real act of mercy on her part, because if saw what happened to Tottenham last weekend, it was an embarrassment. I don't think there's another way to describe it. And I'm thrilled, actually, that Ian Rowe is not with us this week because he's a Newcastle fan and he would not have been able to resist, which is a good thing. I guess the other great thing that happened this weekend is I got to spend a whole bunch of time with my granddaughter, which I don't do often enough, including at a street fair yesterday where she managed to get herself painted as a cat. It's amazing. Kids they're 5 and they have no discipline unless they want something. She stood in line quietly for 40 minutes while she waited to get painted as a cat and then immediately turned back into a 5-year-old. So it was a remarkable moment, but it was a great time. So with that, why don't we get started? As I think Jörn mentioned, and I mentioned as well, this is an episode we've been looking to do for a while. We've talked a bunch on this podcast about clinical care pathways and about different specialties having a role, but this seemed an appropriate week, and Cyrielle seemed an appropriate person with whom to focus on the interplay between endocrinology and hepatology, which I think will be so pivotal in all this moving forward. If you over on Rising Tide, our other podcast, Ken Cusi likes to talk about diabetologists need to get comfortable with FibroScan or endocrinologists need to get comfortable with FibroScan, and hepatologists have to be comfortable prescribing GLP-1s. But at a much more basic level, as Cyrielle described, the point of juncture between the two and the area of overlap is only going to grow as we all come to learn more about about fatty liver and it becomes more part of medical care. So what our goal today is to take a look at that interaction from both sides, both in practical terms, care pathways, handoffs, working together, and then maybe to go back and take a look at areas of knowledge and ask what does each specialty have to teach the other that will make them more effective at what we do. Jörn, I'm going to ask you to start, in part because this was your idea in the first place, and in part because whenever we talk about clinical care pathways, I always turn to you. So why not now as well?
Well, yeah, thanks. And again, I think it was the right time to get Cyrielle on alone to hear her thoughts on, developing a joint institute in France is just the right path forward. And we've discussed on several occasions the need for referral pathways. But what's crucial, and Cyrielle, you're really somebody who sets the scene here in terms of endocrinologists, is to learn from you, how can I communicate with my colleagues out there in endocrinology, and what can I tell them on how to use those NITs, which we've developed as a hepatology community, which you know very well, but they're not used at this time with the same rigorousness, and for a number of reasons. And one might be, does it make a difference in the management of my patient? How could I potentially deal with a positive test? Does it mean I have to refer? Maybe I don't have somebody to refer to. So I think there's a number of practical issues that, from my perspective, hinders colleagues in diabetes practices today to screen for this. I think my first question to you, or something we could discuss, is maybe how can we overcome these barriers, or how to have somebody who hasn't the knowledge and hasn't started screening for liver disease in his population like you're doing. How could I approach him, and what should I, maybe discuss and offer for him to be interested in this type of patient identification?
The main thing is if you want to implement this pathway, both sides need to cooperate, and you need to get the endocrinologist on board. We have this discussion saying that we already do a lot of checkup on our patient, especially in patients with type 2 diabetes. There's a yearly checkup that we're doing to check for any diabetes complication. We look at the eye, we look at the kidney function, we do exams for nervous system checking up. And I think really it's time now to add another organ in the setting of the checkup, which is the liver. And you need to probably show the benefit that there could be for the patient if they know that they have diabetes and NAFLD. And most importantly, and I think this is where it can make the difference today, even though we are talking a lot also that there's no treatment. And we did a presentation lately on a symposium showing clinical case where you do see patients that are diagnosed with cirrhosis or even with HCC, whereas they have been followed by endocrinologists and diabetologists for a few years, and the liver were never checked. They did not have any liver imaging, even though the liver function tests were sometimes mildly elevated. So I think it's where it would be very interesting, to talk about these clinical cases and the fact that if we don't check for the liver, if we don't look at it, we may miss a certain number of patients with advanced fibrosis, with compensated cirrhosis, that we wouldn't even suspect to have cirrhosis. And this is where the risk of having HCC, the need to go in a screening, the need to see an hepatologist is important in terms of prognosis. So probably it's the first step and one way to interact with endocrinologists. They may not be aware of this risk. They may not be aware that they may think that they would know if a patient has cirrhosis, whereas we definitely see every day, not every day, but in the clinical practice, we do a routine screening for advanced fibrosis, and regularly we do diagnose patients with advanced fibrosis and cirrhosis, whereas they had no symptoms. So I think it's really one very strong message to bring to the endocrinologists to get them involved and to convince them that at least in the yearly checkup we should perform the FIP4, and then if it's elevated, now it's very clear that we have many non-invasive tests that we can propose, including liver stiffness measurement with a FibroScan, and this is something that needs to be done nowadays. So
that's a strong message. And let me just file in the others. We had this discussion on a patient that I've seen because there were some abnormal lab values, and he's been under care for quite some time, even in my hospital. It's not like they were outside somewhere where nobody knew about this. I wasn't involved. And it turned up when I did the staging, the person had HCC in NASH cirrhosis, which went unnoticed for quite some time. So I think this was the case we discussed, and we both felt that if he would have entered a checkup for liver disease at one point, that could have potentially had a different outcome. Now, we don't know that for sure, but I think you mentioned a very important point that these patients are actually under care. And with the endocrinologists, this might be the lowest hanging fruit if we want to start in high-risk populations, because your colleagues and yourself, you're so experienced in checking on complications. So I thought that was a very interesting case indeed.
Yeah, exactly.
I think it's an interesting point, Jörn. I mean, when you go back and take a look at the histories of many of the patient advocates in fatty liver, you see the same story. Today, 50% of all cirrhosis is diagnosed for the first time on the occasion of a decompensating event in an emergency department. And the story that, for example, Tony Vegliati tells, or Wayne Eskridge tells, or Terry Milton tells, fundamentally the same story, except that Wayne got picked up a little bit earlier, which is that they were told that they had a little bit of fat on their liver, but not to worry about it. And then one day, 15, 20 years later, somebody says, hey, you have cirrhosis. And I think in Tony's case, it was HCC as well. So the ability to pick those cases up earlier would be fantastic. You believe endocrinology is the right place to do that, Jörn, or just the lowest hanging fruit? Is that because it's the right place or just the easiest group to approach on it?
Yeah, I think that's for two reasons. A, it's a high-risk group, right? So we know about the prevalence of advanced fibrosis in this patient population is high. I mean, there are other groups that have a high risk, but this group is specifically already included in medical checkups and programs. And in Germany, we have the disease management program. And I think it's very comparable to France, where they get, I believe, once in a year a big lab, and they get A1C checks every 3 months, and they go see their physician. As Cyrielle said, they get a urine dipstick every once in a while. And it would be so easy to hitch on because they are under care. And we just have to let them know which tests. And I think we already developed the answer in the guidelines. We're saying which test. It just has to be implemented now. And I think this is where Cyrielle and I have been talking. There are barriers, and it takes time and everyday clinical practice to really reach everyone. But I do think that in that population, we do have the highest turnout, or for the investment, the number needed to screen to actually find cases is the lowest.
Yeah, and if I may add something, I think the most important thing is getting the endocrinologists to be convinced. And I think there's plenty of evidence, and we can all of us can talk about a patient that was diagnosed with cirrhosis or HCC, whereas when we look back at the lab 5 years prior to this event, they had elevated liver enzymes. So as you said, it's really the right population to target. But what's changing nowadays is that the guidelines, the most recent guidelines from hepatology field, EASL, ASLD, AGE, but also from the diabetology field, the ADA and the ASAE also now all agree. And also the test that needs to be used as a first-line test is very easy to implement. It's cheap, and we know the threshold. So for us, it's easier to put the patient in the pathway and in a screening, because now everyone agrees on the best way to do it. And I think this is really important. When you looked at the guidelines prior to the last one in 2016, recommended by EASL, the algorithm that was proposed was not very clear. The thresholds were not very clear. So it brings confusion in the mind of an endocrinologist if he doesn't really understand, and if he's not an expert in these non-invasive tests, which is understandable. He has many other things to deal with. So now that everything is clear, that the thresholds that are provided by the guidelines are the same in every guidelines, this is a very strong message. And I think it's now the time to implement it in clinical practice. And it shouldn't be that difficult because, as you said, Jörn, every patient with type 2 diabetes needs to have a lab checkup, and you can easily calculate the FIB-4 score with the lab studies performed. So I think this is key.
One of the things we've learned doing this podcast, or I've learned, is that we've not had, well, you're not the first French guest we've ever had on. We've had a lot for Ratio, for example. But since we've started talking a lot about care pathways, you are. It turns out that the U.S., as best I can tell, is the only country that automatically puts an ALT on a blood panel. Do you have to request that especially in France, or when you draw blood, will that be one of the things that's given back to you?
Well, I do need to request it, but I think lots of patients already have it. You know, we requested, lots of physicians request the liver panel, and we do have AST, ALT. We just ask for a liver panel and everything comes up. So actually, it's very interesting. We had this discussion with endocrinologists in the private practice because we are trying to build a program where we would like them to enroll patients in a pathway using liver stiffness and FIB-4. And actually, they told me that no, they also get an automatic calculated FIB-4 in the lab results, even though they didn't ask for it. So that's interesting as well.
And that's in private practice? That's fantastic.
Private practice, yes, exactly.
Yeah, I think the situation is a little different. In Germany, you have a lot of liberty, but they won't do anything automated. So a lot of the endocrinologists I talk to do, for example, like a GGT, but no ALT. And then I think the discussions we're having here are so useful because you're really master in speaking to these colleagues of yours. They will more likely listen to you if you transfer that message that's, I think, more authentic compared to the hepatologist requesting that. And that's why I enjoy, I think, our interaction, because we can both learn from each other and form our field, and that way move it forward jointly, which will be much easier.
Yeah, it's true that it's always easier to talk to his peers. And actually, I was surprised when we just put a little survey to ask the endocrinologist from Lyon area, would you be willing to participate in this program? They were, most of them said, yeah, we would be happy to, collaborate and look for the liver. So I think awareness of what is NAFLD and what should be done starts to come, because there's more and more communication as well in endocrinology meeting. For example, we had the French diabetology meeting a month ago, and there were sessions regarding NAFLD. There's not so many, but they were completely full. The room were full. So I think there's more and more interest, and it's a very good news that you can see that our colleagues start to get interested in the disease and how we can screen. We also had a session regarding treatment and anti-diabetic treatment in patients with cirrhosis. What are the recommendations? We have a working group between the two society guidelines in France, and pathology and diabetology. So we did guidelines regarding the treatment for diabetes in patients with cirrhosis, and it's really helpful to get this interaction and this symposium when we bring the knowledge of the hepatologist and the knowledge from the diabetologist, and how we can manage this patient that actually we both see on different sides of the disease.
I thought it was fascinating listening to Cyrielle there, and I think several things sort of struck me. The encouragement that you're describing of endocrinology coming on board in France. In the past, I've always had the sense that sometimes the not only competition, but they've looked after these patients for years to then find there's a disease that they hadn't picked up. That's human nature, to be slightly resistant to the embarrassment, or I wasn't able to do that, particularly when we get more and more patients who are quite angry at why didn't I know, why didn't we pick it up? But I think what I'm getting the sense of, we now have more tools in our armoury to help endocrinology and hepatology, and we had joint NAFLD diabetes clinics. But by no means were we seeing 60 or 70% of our diabetes and endocrinology patients. We were seeing select ones from select consultants. Is that the case in France? Are there people who are more on board? Because you described that movement. Would they be in particular areas of France, the research units, rather than the more rural district general hospitals, or is there a sort of divide?
Well, I think you're actually probably right. I mean, it takes time, and you may have endocrinologists that have their own practice for a long time, and they feel like they did the best they could for the patient, and they don't see the benefit of liver checkup. And then finally, and you're right also, even when I was a young resident, I remember looking at abdominal ultrasound, seeing hepatic steatosis, and they were like, okay, it's normal. It's because of insulin resistance. Don't worry about that. It's okay. So this is something we've been taught by the past. And so the knowledge of the disease, the awareness that they can actually progress, not all of them. And this is what is tricky as well for us to understand. The hepatologist knows very well the natural history of NAFLD. We know that it's only a small proportion of the patient among this large population that will progress to the advanced stage of liver disease. So there's more and more understanding of that. Not everyone has NASH, even in type 2 diabetes. Not every patient with type 2 diabetes has NAFLD to begin with. So trying to understand that you need really to risk stratify your patient, try to classify them between you have NAFLD, you have probably NASH, you may have advanced fibrosis, is something that we need to work on, and it's not very easy to get it. So probably you're right, it started with tertiary department in endocrinologists from university hospitals, but I really have the feeling that now it's spreading in other settings, and probably in a more, like we said, private practice or small and general hospital. But one thing is also very important is that even if every diabetologist and endocrinologist in France are convinced, we do not see every patient with type 2 diabetes. We are not enough. We have numbers saying that we are seeing probably approximately 20 to 30% of the type 2 diabetes patient in France, and the rest is followed by the GPs. So there are still, some specific area and some patients that we probably won't be able to target. So we really need to work all together to get the patient involved in a screening pathway for the liver.
Yeah, it's probably a similar picture in Germany. There are specialized diabetologists and also qualified through through a disease, through a program of the German Diabetes Association, but they tend the minority of patients. The vast majority is with primary care. But there it's more diluted. And that's why I said I think if we really want to get most for the number of screens we do in terms of advanced disease, it's really the endocrinologist. The message that Cyrielle and I am sending here together from this podcast and various places that we had the pleasure and honor to be speaking together is much stronger compared to one faculty speaking on his own specialty maybe. That interactions really help both of us develop and understand the other better in terms of what's the needs, how can I approach the different disciplines, but also sends a stronger message. And I think that's important. And for all the practitioners listening there, I think it is important we use these simple tests and decide on which patients should be referred for further management.
Yeah, absolutely. I just wanted to add, it's exactly what Jörn said. It's probably harder to say, I'm an hepatologist and I'm telling you what you should do as an endocrinologist. But the thing is, I can testify, we are doing it. We have implemented a systematic screening in the department where every patient have at least a FIPRO. We do have a liver stiffness assessment if needed. We are not performing it to everyone. We are using the algorithm proposed by the most recent guidelines. And I mean, it's working. So it's not the same thing saying you should do that and saying we are doing it. And we do feel that we bring benefit for the patients. So I think this is a very strong message.
Can I ask how the patients respond from an endocrinology department when they're told that they've got a liver health condition, excess fat or some fibrosis? Because some patients that I come across in different diseases go, don't tell me I've got something else wrong, because they're medicalized, so they're in that medical pathway. Whereas what I see in lifestyle is the opposite. Well, why wouldn't I want to know? Because it's something I can do and it's something I can do something about. In relation to FibroScan seems to, in my experience, engage people's focus a little bit more. And have you ever looked at the comparison of who changes weight or HbA1c in the group that have been versus the group that have not been FibroScanned?
Well, we did not look at it in a clinical research setting when we compare groups. So I can only share my clinical experience. And there is some people, I was actually one time very surprised. We have a patient, she has obesity and we were, and probably also type 2 diabetes, but I think our major problem is she has severe obesity and she was struggling to lose weight, even though she has met several times the dietitian. She had lifetime counseling and it was challenging for her to engage and to actually, apply this recommendation. And one day she comes for a checkup and we say, we need to check on the liver. It's recommended. So she had a liver stiffness assessment. It was not very elevated, but, just in the middle between 7 and 8. So she started to be worried. We use a color code when they put the threshold 8 kilopascal. You need to be seen by a specialist and an hepatologist between 7 and 8. We need to check a little bit next year to make sure that it doesn't progress. And it's very visual. So she actually saw that she was in the orange area where she could move to the red one in the future if she doesn't change her lifestyle. And the next time I saw her, she had lost weight and she really focused on getting the liver health improve. And this has been something that acts like a motivational lever for her. And it's a good thing. I mean, she couldn't find a motivation to lose weight just to lose weight, but being convinced that it would improve her health status regarding the liver was a very good thing. So it doesn't work for everyone that way, for sure. And there's other people that may not find the benefit, but for some, it can be really engaging and really helpful to actually change the lifestyle and lose weight. And so that's the good part. And most of the time, when we talk about checking for the liver and performing a liver stiffness assessment, the patient are willing to do it. They want to know. And the good thing also is that most of the time we can reassure them because the expected prevalence and the proportion of patients that actually does have elevated liver stiffness is not that high. So based on my experience, I would say that the majority of them, 60-65% of them, we can just say everything is okay, the liver stiffness is low, and that's fine. So it's not adding so much burden on our side. I mean, sometimes, people must be worried. I will do a liver stiffness assessment, but then I don't feel comfortable, talking about the results. So that's really important as well. Try to understand what are the thresholds, what can I tell to the patient, and most of the time it's not that hard because you can actually actually reassure your patient that was probably worried to see the elevated liver enzyme or knowing that he has fatty liver. So when you can reassure them that it's not an advanced disease and there is time to improve, it's also a very positive message.
That type of biofeedback, and I think, Louise, you've mentioned that numerous times also in this podcast and offline. I think it also works for my patients. It's very visual.
Can I just take you slightly in a different direction, Cyrielle? Yes, I met you in Barcelona, but I listened to the virtual presentation you did in Paris NASH, and I was really, really interested in the chronic kidney association with I think it was 5 phenotypes, 2 of which you detailed were directly related to NAFLD and NASH. And you've obviously done some work on FibroScan in chronic kidney disease and that association that FibroScan can predict chronic kidney disease to some extent in the diabetics from recollection. But that really, really fascinated me. If we can start to select chronic kidney patients who are at higher risk because of their phenotype, I thought that was such an exciting presentation.
Well, thank you. Yeah, actually, it's so the work is from, the large Swedish cohort where they were able to classify the patient. The idea is that basically in your mind, you have the type 1 diabetes, the type 2, and a few of them that late on stage diabetes, which is also autoimmune with antibodies. But you clearly see that among the type 2 diabetes, it's so vast and there's so many patients with a lot of heterogeneity. They were able to classify them into 5 different clusters. And what is really interesting is this cluster is made right at the diagnosis of the diabetes. So at the moment you diagnose the disease, the patient may have different clusters based on insulin resistance, based on the BMI, and based on the presence potentially of NAFLD. And the prognosis is different. So this is actually very interesting to see that, as you said, there is a specific cluster, the third, that's SIRD, which is associated with higher progression rates toward chronic kidney disease and also toward cardiovascular disease, actually. So this is a very, very specific population that you can catch very early on, and you can predict whether they have a higher risk of progression. So I think this is also something that probably doesn't really put a lot of interest in the side of the hepatologist, but in the side of metabolic disease and diabetologists, it's something that we are really interested in, knowing which one of our patients may progress, which one may be at higher risk of diabetes complication. And so that's really informative as well. It could advocate as well to check for the liver status, because classifying your patient based on the presence of NAFLD or not is also classifying your patient regarding the prognosis of diabetes and not only the prognosis of liver. So it's really something that is very fascinating. I think there's more and more work to do regarding the interaction between the liver and the kidney. Probably there's a pathophysiological pathway regarding the fibrosis that you can find in the kidney and the liver that is at stake there. And I think there's more and more discovery to do on that side in specific population with kidney disease and the liver disease.
Let me add 2 thoughts to that, because I think it's very interesting what Cyrielle mentioned, and I'll hand it back to you, Roger, is one, you can argue this is just all coexistence of diseases, right? And over time, the metabolic risk factors adds up. But I think we're seeing patterns where, we get certain mediators that are activated in the liver add to the vasculature injury that's important for the heart, but also the kidney, and that adds to that phenotype, a certain immune activation in the inflamed liver that does have outside effects. And even collagens as a signal that are produced in the liver through stellate cells could have an impact here. So I'm very closely with Cyrielle here that I think through the staging of liver disease and let's say the immune activation, the fibrogenesis that's happening, the outside organ injury is independently of just the metabolic drive that injures those kidneys in parallel. It's probably an augmentation that we see, and we're learning here through the cohorts that are being established.
So do we think, from what I've listened to so far, going back a little bit in the episode here, whether or not it's worth looking at a metabolic blood profile, that it includes some of the essential, obviously, liver, so that we could do nephrofibrosis, FIB4 plus HbA1c, and all of those sort of to design something that may well be more comprehensive given the vastness of metabolic syndrome and disease. So bringing all of those collegiate organizations together to say this is what we consider essential.
I think it's an interesting thought. The message, of course, we want to send is simple, and it's easier to be specific on one organ system, right? You could think of doing like a metabolic periodic screen. And I think from a research side, that'd be interesting. But if it comes to practicality, it needs to be very closely linked to a consequence to the physician and to act on a certain test. So I think we need more education if we go down that line to really explain why this test has been done and what it means in terms of follow-up.
Jörn, that makes sense to me. If I remember correctly, the cluster in the Swedish study that's most strongly associated with fatty liver, kidney, heart, all that was the strong insulin resistance cluster. Do I recall that correctly?
Yes, exactly. And also what I was pointing out, the study was not designed like that, but when they look specifically on liver enzyme and test and signal using, surrogate of fatty liver, and it was interesting to see that at the diagnosis of the diabetes, there were some patients that already have NAFLD, and these are probably NAFLD-driven diabetes, meaning they had first insulin-resistant hepatic steatosis, and then it leads to the development of type 2 diabetes. Whereas there are some other subtype, and there's another cluster where it's diabetes first, and then they may progress eventually with age with fatty liver, and this one probably are the one that may not develop severe stage of liver disease because the onset of NAFLD comes later. But the problem is, this is a very nice study when you pick everyone at the diagnosis very early on. Most of the time, when you meet a patient and when a patient is referred to you with diagnosed with type 2 diabetes, you have no idea which was first. Was it NAFLD? Was it diabetes? And if he had steatosis now, what does it mean? Does it mean that the exposure of fatty liver has been ongoing for more than 20 years, 15 years, or whatever? Or is it, So this is the thing that are very difficult to catch in clinical practice. And this is where, going back to something very practical, clinically applicable, we need very easy tests. And what has been shown is that if we use a very simple test like the FIB-4, we are able to catch a certain number of patients, and which is associated with a prognosis of the disease regarding liver disease, but also global mortality and prognosis of cardiovascular disease as well. So it's interesting.
Did PNPLA3 play any part in the difference between the groups at all?
Probably yes. I didn't recall if there were one study showing an association, but the thing is the PNPLA3 is very, very strong signal and associated with the development of hepatic steatosis. So I'm not sure, and we would need to demonstrate that it could be useful, for a screening and a genetic screening, which has not been demonstrated, if I'm not wrong. Jörn, you may comment on this, but you can catch specific population, but then it's still the prevalence of PNPLA3 is quite frequent. So the frequency of the allele is quite important. So it may be not as useful as a clinical test and to pick the patient. But yes, of course, PNPLA3 is involved in the disease for sure.
There's strong determinants. And as a colleague said the other day, it's genetics that loads the gun, but it's the environment that pulls the trigger. And you need the impact. And just to follow up on that, there was 1 month ago in actually the Nature's Journal, there was a hair analysis of famous Beethoven, as you might have seen or not. And he was actually a PNPLA3 carrier, and the source of death was cirrhosis with ascites, and it was always blamed on his alcohol consumption. But on top of this, they actually figured out he was not only PNPLA3 positive, but he also had Hep B in history. So he was quite liver diseased, and even at that time, PNPLA3 probably did his share to his death.
But the irony of Beethoven was he lived to the average life expectancy of somebody with liver disease in the 1800s. What does that say about modern healthcare? Because I think it was about 57 or 58, wasn't he? And that's the average age of death in the UK for somebody with liver disease. So it's a bit frightening. And that's only one disease, not three.
So you're suggesting we've not made a ton of progress in the last 200 years on this, huh?
He did well being Hep B, PNPLA3 and alcohol. So he had multiple diseases, yet managed to get to a relatively fair age with the medicine available in those times. So I don't know. You answer that question.
Louise, I have to tell you, I'm hearkening back 1 week to the audio engineer drinking game, and that your winning entry was keep it simple, stupid, or not your winning entry, but the line most of the comments associated with you was repeating Stephen Stephen Harrison's admonition to keep it simple, stupid. And I'm wondering, and Cyrielle, let me ask you this. If the trick is to make this simple enough for endocrinologists who are not working at institutions with a joint clinic to become engaged, what is the simplest pathway to do that?
Excellent question. The best way would be first automatic calculation of FIB4, because then it pops in your eyes directly when you look at the chart and the biological chart. But then easy access to try to find a way to then have an easy access if needed to liver stiffness assessment. So there's multiple ways to do that. You can use platforms. It can be implemented in a clinic close to you, but definitely you need something very standardized, doing always the same process and with easy access to the different step of the screening algorithm in order to make sure that it would be working. And then at the end, you need to have your favorite hepatologist. You need to know where you will refer, and you need to have the whole pathway. Otherwise, it may not work. So identify in the setting, in the community, who can work with you, but you really need to interact. How am I doing it? What step each of us is going to perform? And it's really, there's no other way than talking to each other. I think this has been very helpful in Lyon Hospital. We have a monthly board with hepatologists when we discuss cases. And this is how we get to implement a smooth pathway where, there is no question at the end because we agreed on every step and how we can refer the patient. So it takes a little time, that's for sure, but interaction and communication remains a key factor to implement this pathway based on my experience.
And it's a very strong message, Roger, because it's so simple, right? And I heard Cyrielle, and I think, sometimes I got to talk to my peers and say, we got to be ready to accept these patients. When somebody reaches out and says, is this pre-cirrhotic or cirrhotic disease? That's the challenge on our side. And I think, and talking with each other, I think we can develop this.
Yeah, Jörn, thank you. That's exactly what I was thinking, which is that's simple to execute once, in fact, everybody's bought in. And it may even be reasonably simple to get endocrinologists to buy in once hepatologists are working on it. Or if you have someone like Cyrielle who actually trained at San Diego, but that's not going to happen that often. So it really does come back to, what does it take to get the hepatologist, A, to become more committed to fatty liver disease, and then B, more committed to the idea that they may be a key conduit to get patients picked up earlier in endocrinology practices. What does it take to do that, do you think?
We got to align with the endocrinologists on the NIT to be used, and I think the FIB4, as highlighted by Cyrielle, is a very good one. There could be a nurse practitioner, for example, Louise, being intermediate to do the FibroScan and actually funnel for the gastroenterologist, because they're not going to see patients with an intermediate score that then all end up just having fatty liver but no advanced fibrosis. That's the challenge on the gastro side, because they have a busy agenda and they'd really like to not see a lot of people. So we got to send over the right ones. And I think that intermediate step, and that's going to be very system dependent, depending on, what referral pathway are you working in. Is a nurse practitioner in between reliable? What's the reimbursement for tests? And also, what's the distance to the center the patient would have to drive? That's the next dimension, right? So if somebody has to travel then for a long time to see a specialist, I think the patient might not show up. What would further help? I think the information we're gathering now, we're seeing the medical information. Physicians do care, as do patients care about their health. It's not about, revenues. We want to provide the best practice. And if we know this is a high-risk patient, increased risk of death and complications because he's in the high FIB4 category, then we're ready to act on that and try to do something. And to do something is the last thing, because the gastroenterologist is going to say, I'm not a nutritionist and I'm not an endocrinologist, so what can I do and offer to the patient? And I think we're so close to having liver-directed therapies and making a recommendation for a certain therapy where there's evidence that's potentially approved for another indication, that those three challenges, A, the referral using an NIT, the reimbursement in the specific system, and the management of the patient with advanced disease is what needs to be determined, and more gastros are buying into this.
No, I think you're right. And I think that intermediary is obviously where I talk a lot about allied health being educated, because we are the ones who are going to be the educators, and yet we're not being educated. We are the ones who interact with the patients most of the time. We are the ones that the patient calls to send the message to their physicians, and vice versa. We ran a FibroScan service which is different to FibroScan for hepatology. We received referrals from sexual health, from rheumatology. All of our rheumatology patients were screened pre to starting methotrexate. Most of those on methotrexate were now screened, but dermatology, renal. So it was an all referral system. So it was for anybody who had a potential liver health problem, not purely liver disease. And we would take out the liver disease. But if you've got that skill set, you will tell the physicians who they need to refer. You will discuss the scan with the physician, whether it's a renal physician, because that's your strength. And that is where that intermediary comes in. We do not expect, or certainly the role I have now, I do not expect all renal physicians or diabetologists or dermatologists to be experts in FibroScan. But as Cyrielle says, we've got clear parameters. We've got clear settings that we can discuss, and we know our field as intermediaries for that. And I think that's the key. I had somebody this week who had a FibroScan in a liver centre, has gone off and lost 2 stone, but actually didn't want to wait 2 years for the next scan and was high-fiving because that had made such a difference. Normalised liver stiffness, normalised liver fat. And that encouragement, because they're struggling with their job at the moment and work-life balance, can throw out their good work. So it's having that ability to have that intermediary to do that and have that skill set. And obviously it's something I argue for a lot, but it's where we have to go. You can no longer just sit in a clinic with one machine and an endocrinologist. You would be swamped by the patients you do, and you would need to take too much time. So we have to find that balance of the best screening techniques, the FIB4, the right people through either ELF, FibroScan in the recommendations. But I think going back slightly to Cyrielle's evidence on chronic kidney disease, I think what we look at for FibroScan is it is not just a test for the liver, it's a test for a poor liver that can indicate other conditions. There's some evidence on FibroScan in ITU. If it's over 17, mortality is very high. It doesn't necessarily be liver disease, it's liver engorgement. So I think we are intermediaries, and I would argue that we need more of us to be able to do that in that skill set.
So how practical is that in the setting, Jörn and Cyrielle, in the settings that you're working today? How practical is it that you get more of that support in your institutions? And what do we have to do to get there?
Excellent question. Well, I think it's key, nurses and platform. Yeah, definitely. It can provide more time to get access to the assessment, saving medical time. It's absolutely necessary to bring more, nurses in the French system. They are not very well implemented and use as they should be, I would say. But definitely we need more. And actually the FibroScan as well in my department is performed by the nurses. So this is really important.
I would implement it at the hospital level. I mean, this is a whole different thing, even in the inpatients, and argue. I get about 1 consultation a week for a patient that decompensates after major surgery. And somebody didn't know they had cirrhosis. And this means they have an extra 10 days on ICU with respiratory time, with infection, potentially lethal complications, just because we didn't see cirrhosis before we did surgery. And these type of things can even be at the, we're not talking identification of NAFLD, but the cirrhosis identification for a healthcare system here could be crucial. Now, in our specific question, I think it would be in the interest of the hospital to provide this additional service, and it has to be very carefully set up how it's reimbursed in the specific systems. The hospitals don't always have the same capabilities as outpatient clinics, and therefore this might be even prior getting to the hospital, but it depends on the system that you operate.
So we're getting to the top of the hour, so I think it's probably time to look to a final question. First of all, Cyrielle, Jörn, Louise, thanks. Fascinating discussion. I think really important stuff. And we're covering some territory here we've never covered on this podcast. 187 episodes in, that's an interesting challenge to meet. If we can cover new territory every week, I'll feel really good about that. So this is great. Closing question. Each of you has a magic wand. You can touch one thing in this structure, and in 12 months from now, it'll be exactly what you want it to be. What's the one place you would touch?
Can I go first?
Sure.
Yeah, you can.
I would transfer Cyrielle next to my department, and I would want to be working with her in a joint research composition here and have a joint gastro-endocrinologist service.
Yeah, that's probably, as you said, we have set a very special skill, but it took a long time and a lot of training to get to that knowledge. So probably magic wand to spread the word and spread the knowledge everywhere so that we are all in the same level. That would be fantastic.
Mm-hmm. That's the realistic approach. Yeah, I think It's the working, extending the working together. I think that's what it is. And it just takes time to approach the patient. And I have the same experience as Cyrielle said. If you start talking to your endocrinologist and say, well, this is interesting, what can you offer? And they know their patients are multi-system diseased, and it's just implementing it in very busy clinic days with all of them doing excellent jobs every day in managing those patients, and just adding a little bit is just a challenge.
I suppose my magic wand is the practical side, that I would look at introducing the screening and maybe the liver at pre-diabetic level so that they're used to it very early, and then we do it. But we're also looking for the more severe disease in the established diabetes clinics so that we're going to reduce it coming forward and find the severest cases. So if I had that magic wand, there would be the stratification of FIB4, the ELF, FibroScan, and some evidence at EASL last year was do FibroScan in type 2 diabetes before FIB4 was some of the papers that I'd seen as well. So either way, but let's stop the pre-diabetics getting to cirrhosis and use liver engagement very early so it becomes a yearly thing for them and they don't know any different. And I think that's the key. Those who are long established will know different when we start to introduce it.
Louise, I think our wands are in similar neighborhoods. If in fact the wand has a place where it lives, it would be a similar place. If in fact we started at the same pace and with the same frequency that we test pre-diabetic and diabetic patients for their other complications, neuropathies, nephropathies, eye issues, we incorporated liver on that list, starting at pre-diabetes, I think we would start to see enough data and enough experience quickly enough that everybody would get a lot more serious about this. And that's probably, I think, the fastest practical way to get there. And I'm with you. I love Jörn's solution. And in fact, if we could clone Jörn and Cyrielle into about 1,000 pieces each, drop both of you down in all of the world's major academic and large non-academic institutions, we can solve this problem in a week and a half. You realize that, right?
Yeah, that's ambitious.
So how are we doing with cloning these days?
Treatment at the end, but this is the other magic wound. But hopefully it's coming. But effective treatment would be the cherry on the cake, right?
So Cyrielle, again, thanks for joining us today. This has been a great episode, and everybody say goodbye. I'll be back with Business Report in a few minutes, and let's not let this be your only time in this podcast. I'd love to have you back more often. Okay.
Right. Thank you for having me. It was a I had a really nice time with you guys, and I think there's more and more we can talk about. So definitely,
we agree.
Happy to join again.
We agree. We'll make it a dialogue. Okay. Thanks, everybody. Bye-bye now.
Thank you. Bye, Roger. Bye, Cyrielle.
Bye-bye.
Bye, Louise.
Take care.
And now for the Season 4, Episode 18 Business Report.
Slava Ukraini, Heroyam Slava. Glory to Ukraine, glory to heroes. As we wait for the spring counteroffensive in Ukraine, really not much to say, except let's hope that the world goes well. We're seeing craziness sprouting up in other places. Sudan has been a horror story this week, but let's just hope that the world can find its way to peace and that democracies and forces for good can prevail. Slava Ukraini.
Thanks to everyone who sent birthday wishes.
Last week's episode was a tremendous success. We always wonder when we put out a large number of conversations whether people are going to take the time to listen to them. But in fact, you've responded to all of them quite well, and we've gotten a bunch of wishes from people and thank you notes and stuff like that. I appreciate each and every one of them. I am trying to get back to everyone with personal notes. If I've not done that already, I will within the next couple of days. And now, I think this is a great episode to roll into our 4th season, and I'm excited.
April downloads are slower than any month in Q1. But that's not entirely a surprise.
As you may remember, April got off to kind of a choppy start. The first episode was late, and we have not had any of the major events that populated each of the first 3 months of the year. So our numbers will be down, but our listenership is still good. We're still getting a lot of response from countries, and Rising Tide is rolling along quite nicely. So stay with us. This is a great episode. May's going to have great episodes. Everything will go well from here.
Our spring schedule is not full yet, but what we have is fantastic.
Now, I can't talk about everything we're going to be doing this spring because we're still working on it, but we will have an episode on the use of VCTE in the EU. We will have coverage of Barcelona. We will have a preview and coverage of the EASL Congress in Vienna. We will have coverage and maybe another preview of International NASH Day. And we should have some fun things sprinkled in the middle. There'll be a lot to listen to in the next couple of months. Stay with us. You'll have a great time. And with that, I'm done with this abbreviated business section. Thanks for staying with with us this week. I'm sure you'll enjoy this episode. I think it was really good. And I hope all of you keep in your heads the images of Mazen and Cyrielle playing one-on-one basketball. It'll be a kick. So I want to thank Magic Mike, Steve, Eric, Jake, everybody who helps get this episode out the door and has been working with us this week. And we'll be back next week with our next episode. So until then, stay safe, surf on. I'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com and we will answer on the podcast or the website.